Hi, good afternoon. Um, there was somebody who made a comment earlier about the universal language of English, and as an English man, I am particularly grateful for this phenomenon. It makes my life so much easier to do what I do. Um, okay. Thank you for the invitation to be here today. Um, I've I've had some opportunity to listen to people this morning, and I think first of all this is a moment for solidarity. And I've talked with some of my colleagues who very much feel connected to the situation you are facing at the moment, and certainly want to be able to help in some kind of way. And I'm mindful that in the introductions there's an idea about something happening between now and 6 months' time. So I've tried to think about what might be my contribution to what might happen between now and then. I'm sorry that the representative from the Hearing Voices Network is not here. And that's a little bit selfish because I am very much involved with the Hearing Voices Network. One of the things that you'll see on the screen here is a book that I wrote a few years ago with actually some Dutch researchers and some service users around the experience of recovery for people who hear voices. And to make the connection with the network here would have been very nice. There are some people on the platform here that also have a connection. I think Bernard Ute lives about 5 minutes away from them. And Philip did all the statistical analysis for their research some years ago. The other thing I should also mention is that I'm very much involved in the NGO sector. I am a practitioner. I work in a mental health team as part of my job at the university. I work in an assertive outreach service. But I also recognize and have been involved for many years with what I suppose are called NGOs, voluntary organizations. I'll come back to one in a moment. But I'm currently chair of an organization called Soteria Network. And this is a group that are very much interested in developing alternatives to hospital, and particularly for people with psychosis, alternatives that do not begin with the idea that medication is the first line or only line of treatment. So even within very modernized, well-developed mental health services, the NGO sector, and I think this has already been said by my two colleagues, the NGO sector is critical to the success of a good community mental health system, and alternatives to the traditional ways in which psychiatric services work are also important. This is a house, Soteria House, that we developed in Birmingham. And this was developed as an alternative to acute psychiatric hospital. I mean, Bernard said that it will take a long time to get rid of the psychiatric hospitals, and to some degree, psychiatric hospitals, I think, will be part of the way we deliver services for a long time ahead. But the idea behind this house was that for many people who are in crisis, although staying at home isn't possible, actually going to hospital isn't necessary. This house was run by ex-service users. It was staffed by people who had used services, who knew the experience of being in crisis, and provided a 24-hour supportive environment for people in a difficult moment in their lives. This is exactly the kind of thing that Soteria Network is about, and if you don't have the opportunity to yet to look at these types of services, then one thing I would be very happy to do is share my experience in working with these. I also wanted to pick up on a comment this morning about the idea of psychosis, schizophrenia, being chronic. And I hadn't prepared to talk about this in particular. But, you know, one of the things that helped change the way I thought about mental illness, about psychosis, were some longitudinal studies. And these are quite old now, and they've been available for people to understand for many years. And what it suggests, I won't go into it in too much detail, but what it suggests here is that for people with a diagnosis of schizophrenia, actually many do recover. What we don't see in psychiatric services, because traditionally we would lose contact with these people, what we often don't see is the fact that people recover. And what is meant by recovery is that people return to normal kinds of lives, where they're living with family, they've got partners, they've got children, they've got employment. And the idea of partial recovery is that people can return to some kind of a life, even while symptoms continue and maybe while treatment is still important for them. So I just wanted to give this message because I think one of the biggest problems from family members, and I really want to show solidarity with family members, having worked in community mental health services for 30 years, you know, I have seen the suffering of families as well as people who are our so-called patients. And I just wanted to pick up on something, a feeling that maybe when you have a relative for the first time who is perhaps developing mental illness, is not to give up, not to believe this person has a chronic, untreatable, uncurable mental illness. That simply is not the case. Unfortunately, it is for some people, but actually we don't know the difference between those who will recover and those who won't. And a very important message was given to me by a service user many years ago, and she said, why don't you just work with us as if we are going to recover? And I think that's a really critical message for services, is to work as if people are going to recover. And that in itself increases the likelihood that people will. Of course, if people are stuck in psychiatric hospitals, if they are stuck in the psychiatric system, what possibility is there? For me, and I started over 30 years ago working in a psychiatric institute. It became very clear to me that for those people who were stuck in these places, recovery just did not exist. Institutional life is no life at all. So, and I just need to now say something about my presentation. Yeah, so I just wanted to orientate people. Birmingham is in the very middle of England, Birmingham has a population of 1 million people. I suppose it's like Athens in a way because it's very cosmopolitan. The English or the white population of Birmingham will be the minority population in about the next 10 to 15 years. We have many migrants, and this alone was something that made us rethink the way that we delivered our services. We have 3 football teams. We have the magnificent Aston Villa. We have the slightly impressive West Bromwich Albion, and yeah, and I should mention there's another football team, but I can't. Okay. So my presentation or my thinking about the presentation was focused on 2 things. One is that I work primarily in adult services. Bernard mentioned that they are now developing their strategy for children. And of course, there's also a very important population of the elderly. And I guess, you know, one of the burdens to come for the political system, for the economic system, is the development of or the increase of an elderly population and dementia. So I don't want to say that we're forgetting this, but we have to focus, and this is my area of work. And I'm also not going to talk about legal frameworks, but you know, I just want to connect with this importance of how significant human rights are beneath all the questions of psychiatric services. Yeah, and I just wanted, you know, when you said this thing about the human rights of a right to life, I wanted to just add a little. It's a right to a life. That should be the human right, you know, right to being someone and being able to do something with your life. And you know, if psychiatry has a goal, it's to do that. So, and then of course I asked myself, how can I be useful? You know, there are some ways in which the UK is very similar to Greece. This is from some data from WHO a few years ago, and this is the amount of beds that we have, somewhere around 1 to 5,000, and this is the number of beds that you have in Greece. So, in a way, our psychiatric service in terms of hospitals or hospital beds, this suggests it's quite similar. I suppose where there's a difference is that there was a very big investment in our inpatient services. And a lot of those services are now provided in small local units. But I understand that a lot of your services are provided for in general hospital units. Is that right? But there are still some big old psychiatric institutions. Yeah, I mean, one difference is that those types of institutions, those buildings have now gone. As Philippe said, they got blown up or converted into luxury accommodation. So they were well built. I also wanted to just hit the wave we're on at the moment because, these 2 questions are inseparable from psychiatric services. This is a map of where our unemployment is highest, and actually it's about where I live. In the west of the city is particularly bad. But you can see that the spread of unemployment and poverty are very closely linked. And then if you look at where our psychiatric services are, which is the map on the right as you're looking at it, all those dots are our local psychiatric facilities where our community teams are based. And the reason for that is that's the prevalence of mental health problems. We've naturally gravitated to where difficulties are. And the sad truth is that mental health problems are inextricably linked with poverty. And if you're not poor before you have a mental illness, then, you know, the likelihood is your career path is one of likely unemployment and a life living in the hardest communities. Now, I don't know if Bob is going to talk about this later, actually, about employment services. But, of course, in the current climate here in Greece, this is particularly significant.